Welcome to the ACO Show, podcast about the American healthcare system and some of the people who are working to make it better. I'm Sean Cavanaugh. I'm joined by my co-host, Dr. Josh Israel. Welcome, Josh.
Thank you, Sean. Glad to be here once again.
We had another top government official with us today talking about a new model out of CMMI.
We did. It was Jacob Schiff, who's the Chief AI and Technology Officer, a very cool title. And we primarily talked about the Access Program.
Yeah, you mentioned his title. I think that's the first time AI has appeared in the title of someone from CMMI, so times are changing. Yeah, he talked about the Access model, which is a new approach to chronic disease management, very reliant on technology interventions and pretty novel approach.
Yeah, we already have done one show on Access, but I'm glad we've done another, and we may even do some more. It's a little bit complicated. So, Sean, I asked him for an elevator pitch. What's your summary of what this program is? What should a doctor need to know, and what should an ACO need to know?
The way I would describe it is you're a patient who has a chronic condition that meets one of these criteria that CMS has identified. It's either behavioral health, pre-diabetes, diabetes. There are apps and other technologies out there that people are marketing to help you improve your self-care and hopefully sharing that information with your PCP. This is making those apps available to Medicare beneficiaries in a very structured way and hopefully creating a feedback loop to your primary care physician and evaluating it pretty closely and only making payments to the app company when they see clinical improvements. It's the next evolution, both in payment and technology, of things CMS has tried before in disease and chronic care management. And there's enough things have changed and there's enough new technology that it's a good idea to try these things.
Well, let's take a listen to Jacob Schiff from CMMI on the Access model.
We're here today with Jacob Schiff from the Center for Medicare and Medicaid Innovation. Welcome, Jacob.
Great to be here.
You have a background in technology. You worked at Google, Flatiron. You started an AI company called Anomaly, which I've been reading up on. How does someone with that background end up at CMS and the Innovation Center in particular?
I ended up here because the role and the opportunity seemed particularly unique and one that spoke to me and my entrepreneurial background. For context, at the Innovation Center, I serve as Chief AI and Technology Officer. And what that means is I'm focused on how can we evolve how we pay for healthcare in order to enable the fullest potential of technology to meaningfully improve health and healthcare affordability. How do we bridge the gap between what is possible and the status quo, which I knew as an entrepreneur myself, that gap has never been greater and it is only growing. And it felt like a very unique opportunity to be able to go from playing within the rules of the game that are set often centrally to actually being involved and hopefully writing or contributing to better rules so that ultimately we can bridge the gap that I described earlier.
Well, let's talk today about the Access model. Is this the first time CMMI is testing a technology-based model?
It's really our second that closely follows our first, which was the Wiser model using technologies to support prior authorization processes.
And why do we need a technology-based model? Why isn't it enough to just incentivize outcomes and let the market get there with the best available tools?
Well, I love that question because in many ways, Access actually is not a technology model to support your point. It is actually an outcome-aligned payment model. And we can, of course, dig into the context for the model and how it works. But fundamentally, it is not about paying for technology. It is about paying for outcomes, in this case, clinical outcomes, and giving the flexibility around how one achieves those outcomes. It happens to be the case that two things are true, as we'll dig into. The first is that the payment rates themselves are really only viable using technology, and technology-enabled care has historically lacked an optimal payment alternative such that this new payment option particularly resonates with those looking to use technology. But it's not about paying for technology.
To understand that distinction, let's back up a little. And Jacob, could you just give an overview of what the model is?
Yes. So as the name of the model implies, Access is really focused on increasing beneficiary and clinician access to effective technology-enabled care options for chronic conditions. For context, and every listener to this podcast will be aware of the scope of the problem that we're struggling with here. Millions of Americans have chronic conditions, high blood pressure, depression, chronic pain, diabetes. Technology can extend care beyond the four walls of the clinic, can enable overstretched clinicians to deliver better, more continuous care. But the issue is that the dominant payment options that we offer today really haven't optimally supported technology-enabled care for chronic conditions. So fee-for-service pays for very specific activities, and if the way you deliver care does not map to those winning activities, you're out of luck. Shared savings models do better align incentives, especially for total cost of care, it can be effective. But the challenge is it's very difficult to determine what are the savings that are associated with a new way of treating depression or a new way of treating diabetes. And so in practice, new technology-enabled care options for chronic conditions have really lacked a way of getting paid within the system, getting integrated into it. So that's what the access model looks to address, and it introduces a new payment option, which we call outcome-aligned payments, that rewards outcomes rather than activities, rather than savings, and gives organizations greater flexibility around how they achieve those outcomes, including through the use of technology. So what does this look like in practice? An organization, if they're already enrolled in Medicare, they're good to go. If they're not, they enroll in Medicare as a full provider or supplier. They designate a physician medical director. They can then enroll patients into a track in which they have a qualifying condition. A track is a grouping of conditions that are typically comorbid, have shared types of interventions. So we have two tracks in the cardio, kidney, metabolic space, one for earlier conditions, so prediabetes, obesity, hypertension, and dyslipidemia, another for diabetes, atherosclerotic cardiovascular disease, and chronic kidney disease, a third track for depression and anxiety, and a fourth track for chronic MSK pain. They enroll the patient directly or via referral. The first thing they have to do is understand where is that patient starting. So in the case of the early cardio, kidney, metabolic track, it's what is their starting blood pressure, A1C, LDL-C, and weight. They deliver care each month. They have flexibility around how they deliver that care within the bounds of licensure, HIPAA compliance as a full covered entity, FDA. But what they don't have to worry about each and every itemized code, 20 minutes of this, 15 minutes of that. They submit a single claim, a G code each month. And then at the end of the first 12 months, they resubmit the A1C, LDL-C, blood pressure, and weight. And the question is, did they improve that patient relative to where they started by a minimum amount or get them to target? And they have the flexibility around how they get there. We measure what we care most about, which is improvement in health, and we give innovators and care delivery organizations within guardrails flexibility to get there. Hence my earlier point about how this is not about paying for technology, it's about paying for outcomes, but it is also a framework that facilitates the use of effective technology.
So this notion about helping patients better manage their chronic conditions has been around and using something other than just the traditional care system for a long time. But it went by different names: disease management, care management. CMS has done many demos. They typically involved telephonic, interventions, calling and reminding patients, or in some cases, in-person visits. Telephonic was found as pretty ineffective, and in-person was found to be pretty expensive. I think this is where the technology comes in, because like you said, it doesn't sound like you're requiring technology, but it sounds like that's the sweet spot here, that there are new technologies and new approaches to engaging patients in their own care. Can you give us some examples of what you've seen out there?
So earlier, I guess I was describing what is access in practice, and it's about this new outcome-aligned payment option. So that's one of the principles, is let's create this on-ramp. But the other is ensuring that it really complements and extends primary care. And there's a few ways this plays out. The first is that the access organizations themselves, who are once again full providers or suppliers in Medicare, they have to proactively share a care plan update or a care initiation at care completion with a primary care physician or referring clinician if applicable. They have to connect to a health information exchange, CMS aligned network, or other trusted network so that a coordinating clinician can pull updates. They can, of course, also establish enhanced data sharing arrangements. On the referring clinician or PCP side, for their part, because we are collecting outcomes systematically, we as CMS are going to be making available a full directory of all of the access organizations and their risk-adjusted outcomes, so that a PCP, a referring clinician, can make an informed choice about which is the best patient, which is the best organization for them to refer their patient to when they walk in the door with one of these chronic conditions. We've also introduced, we recognize it's important to get paid, and we've also introduced a new co-management payment specifically for this type of care coordination, in addition to other codes that are available, so that when that access organization proactively shares that care plan, the PCP can review it, take one care coordination activity, and bill a new co-management payment for that activity. If they're in a risk-bearing model, if they're in an ACO, for the first year and a half of the model through January 2028, the expenditures that are associated with access, with the outcome aligned payments, do not count towards the reconciliation. So in practice, what this looks like, very briefly, is that today, patient walks in who, let's say, has depression and prediabetes. That PCP has only so many tools in their toolkit. They can refer them to a specialist, they can encourage them to eat more healthily, they can write them a script. With access, they can go to that directory, they can refer them to one of these organizations, they can be certain that they will be involved in that care and get their patients access to effective continuous support in a way that ultimately drives outcomes, because that is the core of this model.
What would the elevator pitch be for a primary care clinician thinking about engaging with this?
Access means new, effective, coordinated care options to help you better support your patients with the most common chronic conditions, covered by Medicare, vetted the same way that every other provider is, grounded in outcomes. And it means that you'll be able to better support them, better support and manage total cost of care, and ensure that you are a key part of that continuous care.
I think I would like that. My first worry as a physician would be, and how do I make sure that I am still the quarterback, that I'm not losing control? I know you're saying I'm going to get a care plan back, but is that enough? I really care about these patients and I want to make sure they're okay.
Yeah. So there's really two pieces there. There's the push and then there's the pull. So I'll explain what I mean there. We mandated a reasonable level of push from the access organization. So what that means is, as I described earlier, it's a care initiation, it's a care completion, and it's if the patient needs to be transitioned because their needs exceed the scope of services of the access organization. So that's the mandated push requirement. Separately, as described, these access organizations need to connect to a trusted network, which means that PCP can pull updates. And by the way, this will mean actually expanded visibility into data that the PCP doesn't typically have, because the access organizations, for their part, need to be collecting all of these measures. And by the way, I'll give another example. In the case of the behavioral health track and in the MSK track, that means patient-reported outcome measures that are very, very rigorous. So it's, of course, the PHQ-9 and GAD-7 in the case of behavioral health. It's similar ones for chronic pain. They're collecting that every 3 months. That's data that now the PCP will be able to pull and have access to as well, to better understand what is happening with their patients alongside organizations that are actually continuously supporting that. Now, importantly, this is the baseline that we have mandated, and we expect that primary care physicians and others will establish, if they so choose, more enhanced coordinated arrangements to be able to even better support patients. But the reality is, as every PCP will know, there aren't enough hours in the day already. There's way more demand for continuous support than that PCP's organization can directly provide themselves. This empowers them with more support and with an organization that is fundamentally incentivized to drive outcomes. And the best way to drive outcomes is to do so in coordination with, not as a substitute to, the organization or the entity that has a trusted relationship with that patient.
So that's the PCP pitch and the PCP experience. Let's talk from the beneficiary/patient. How are they hearing about these interventions? Is it through their PCP? How are they signing up? And then once they're in, what are they experiencing? What's different from their perspective?
Well, I love this and that question, because ultimately it's obviously what matters most is ultimately reaching patients, delivering better health. But what does this mean in practice for a patient? It means new care options that are eminently affordable. So we haven't talked about the payment rates, which we could talk to as well. But for a patient, what this will look like is they are either free because the access organizations can, if they so choose, forego collection of the cost sharing, or at most $7 per month. So these are affordable care options that are convenient, most likely, because they're typically technology enabled. They are connected to their doctor or their care team, as we described earlier, and they're effective from the perspective of they are fundamentally grounded in driving outcomes. So this will mean a lot of additional support and affordable support for patients, where typically today they often do not have so, or it's unaffordable. The way they're going to learn about it will come from a few different channels. We as CMS are going to be massively increasing awareness across really two stakeholders, beneficiaries and referring clinicians and PCPs. So what that means is patients will be, or beneficiaries, people will be learning about those in both of those ways. So sometimes they'll hear about something from a friend who has some great new option, or they'll walk into their PCP for a visit, or they'll have some issue, and that hopefully that PCP will say, hey, there are all these great new covered options. Let's find the best one for you, and I'll stay in the loop, as we were discussing earlier. So it's really about learning about it through a variety of ways, but ensuring that ultimately is seamlessly integrated into their care plan.
The typical CMMI model has cost targets as well as quality targets. And that goes back to the mission of CMMI, which is try to improve the cost and quality for Medicare beneficiaries. It seems like in this model, you're paying access providers specifically for improving clinical measures. How does this fit into the mandate of CMMI, which also has a cost component?
Yeah. So as you said, at CMS, at the Innovation Center, we're really focused on improving quality and cost, and in particular, not increasing costs. The model focuses on improving outcomes, and the savings will really arise from two primary places. The first and the biggest one is really around reduced downstream utilization from improvement or control on outcomes, clinical outcomes that we know are associated with savings at a population level. We know, for example, if you reduce A1C by 1 point, it's associated with a total cost of care reduction of 1.7%. And there are similar measures across each of the biomarkers and PROMs that are associated with the model. The beauty of this model, in many ways, is actually that it enables clinicians to focus on what they want to be doing, which is improving their patients' health, and lets the insurance company focus on what it does best, which is bearing financial risk. And we know if they do their job, the savings will follow. One additional point to mention, which sort of dovetails nicely, is how this model really focuses on prevention as well. And the reason is because the best way to pay for prevention, or one of the best ways, is to pay for improvement or control on the leading indicators of downstream disease. We know today, if there are patients walking around with elevated blood pressure, A1C, LDL-C, and weight, that same patient will have greater disease earlier on than if we help them control it. And what this model does is it proactively does that. It really pays for health rather than sick care, and should further drive savings down the line.
So, Jacob, we're talking about pushes and pulls. For the pulls, some of the incentive, hopefully, is financial. No margin, no mission. That applies across the board to primary care practices as well. Can you talk about the specific payments?
Yeah, absolutely. So there's really two payments. There are the payments for the access organizations, what we call the outcome aligned payments, or OAPs, and then there's the payments to the primary care physician or coordinating clinician, and those are the co-management payments, the CMPs. So the outcome aligned payments for the access organizations, we released those earlier. Payment rates are all available on the model webpage, and they're really designed to be such that they are attractive and viable, especially using technology at scale. But they are such that they certainly require technology in order to be most effective. And we announced recently the initial accepted applicants into the model. We announced over 150 organizations, really spans the spectrum from traditional provider organizations to device companies that are now adding a services layer, to app-like organizations, to technology companies, all of whom, once again, are fully enrolling in Medicare as a provider or supplier. They have all raised their hand and said, in return for that care delivery flexibility that this model offers, we are stepping up and are confident in our outcomes, and we are going to do so at the rates that really assume and require that technology-enabled efficiency.
Jacob, you just mentioned that you just got applications in. So walk us through the timeline. When are beneficiaries going to see these products become available to them? How does this model unroll over the next couple of years?
So the first application deadline, we extended it slightly. The first application deadline closes on May 15th for organizations that want to directly participate in the model as an access participant. It's a 10-year model. It launches to beneficiaries in July of this year, July 5th. And we're going to be really focusing on, as described earlier, increasing that beneficiary and referring provider awareness around that time. Over the 10 years of the model, organizations can continue to enroll to participate. There is certainly a first mover advantage. We talked about the first year and a half, the expenditures not being associated with the reconciliation for ACOs, and just in general, there's a really green field right now around who will become the organizations that become the preferred partners that organizations work with. But it is a 10-year model that we anticipate will continue to grow over time.
Any program CMS rolls out can have unintended consequences. There's a lot of things that could go wrong. I wonder what sort of things you have worried about and tried to predict and prevent.
In theory, one way that one could game the model would be that if I'm paying you for outcomes, but it's not a total cost of care model, theoretically, you could drive up costs elsewhere, including for services for which we really expect you to be delivering that service. So imagine if we're paying an organization for treating chronic MSK pain, and their patients are very consistently during that care period also going and seeking out care for chronic pain at a traditional physical therapist. One of two things is true. Either that organization is delivering very substandard care, such that their patients need to seek out care elsewhere, or they are actually free riding off of another Medicare enrolled provider's care. In order to mitigate that risk, we introduced what we call the substitute spend adjustment. What that does is says for a very defined set of codes that would reasonably be considered substitutes for the care that we as CMS are paying that organization, if above a reasonable baseline, which we set at 10% of their aligned beneficiaries are seeking out those same services during the care period, the access organization effectively gets dinged for that. The other organizations continue to get paid. So that's the substitute spend adjustment, and I think mitigates that risk. Separately, the access organization itself, they have a choice. They can choose to get paid in this outcome aligned payment way, or they can choose to get paid traditional fee for service. This model resonates for those who want the care delivery flexibility that access offers. And that's why for them, if they deliver and bill access codes, that organization cannot also bill traditional fee for service codes.
A number of models out of CMMI have attempted to be multi-payer and to explicitly include other payers. You've done something along those lines here with access, right?
Yes. So the model itself is initially launching within original Medicare come July, but we structured it to really be a framework that could be extended and adopted by payers more broadly, including across books of business, not just Medicare, but Medicaid and commercial. And we were excited to announce in February that 14 major payers representing 165 million people across books of business stepped forward to commit to the Access Payer Pledge to adopt an access-aligned payment option no later than January 2028, which will mean fundamentally that a referring clinician will be able to confidently know that whether their patient has original Medicare or has commercial insurance or a Medicaid plan, that they'll be able to receive similar care options and really expand the impact of this new outcome-aligned payment approach beyond the original Medicare population.
There's a lot of moving parts to this that include referring out to these organizations. Physicians have some trepidation sometimes about the issues around referrals. There are stark laws, as they're called, about self-referral, about financial conflict. Are those issues that you all have considered in this?
Yes. So we fundamentally want referring organizations to be able to making informed referral choices based on who will best support their patient, and rest assured that that organization with which they are coordinating meets certain guardrails. The way this model is designed, thankfully, beautifully accommodates that. So the first thing, as described earlier, all access organizations fully enrolled in Medicare as Part B providers or suppliers. The access organizations are the ones that, for the care the access organizations are delivering, directly invoice CMS, none of the subcontracting that's often been challenging in other initiatives. And then the PCP, for their part, as we described earlier, they directly can invoice CMS for that co-management payment. We did not waive the anti-kickback statute, the physician self-referral law, or STARK, which means that the relationship between the access organization and the PCP can certainly be one that relates to enhanced data sharing, care coordination, but not one that fundamentally involves complex financial arrangements that would be in violation of those laws. So at its core, really what this is about is if you're a referring clinician, looking at and identifying the organizations with which you want to be coordinating care, keeping your options open, because that's fundamentally choice is a big part of this model, and that may evolve over time as new organizations enter, as the best ones for your patients may change, but fundamentally ground that decision in outcomes, and we're going to be making those outcomes available to organizations over time as we collect that.
Yeah, at the outset, Jacob, you mentioned that there's a temporary period, I think you said 18 months, where these payments are not counted toward an ACO's benchmark. But that period will go by pretty quickly. So I think you're right that ACOs, from their perspective, it's really important that they see their beneficiaries aligned with access providers that are generating true clinical outcomes, and not just clinical outcomes, but the best that are available out in the market. So Jacob Schiff, thank you so much for your time today. Can tell you're very enthusiastic about this model, so it's great to hear from you.
Pleasure. Thanks for having me.